Hi, and welcome everyone. It's great to have you all joining us. We're streaming live, so if you want to send to any colleagues, please do so. But welcome to the WHO, the AfroPHC workshop at the African Forum for Primary Health Care. I'm the executive coordinator of the AfroPHC, and we have this workshop every month. And today we're going to talk about rural issues in African PHC. And we're really pleased to have a host of international guests. Professor Bruce Chater, who's going to talk about an overview of global rural health issues. And then Professor Zakir Rahman, who's going to talk on rural challenges in less developed countries with Bangladesh as his example. Dr. Innocent Besigye, the president of African Forum for Primary Health Care, is going to talk about the rural African challenges. Diana Muller is going to talk about team issues in rural African primary health care, and I'll do some fuller introductions as we go along. And I'd hope that Prof. Sanoko will be able to talk about traditional healers, but she hasn't quite confirmed it. So I think that's basically where we are. So we are going to have group discussions. We hope this will only go for an hour. We'll see how we manage with the time. It may stretch a little bit depending on questions and answers. In group discussions, we hope that it can be very engaging. Small group discussions with our guest panels joining you as well in groups and others, and for us to take the discussion forward around some very simple questions, which is what are the issues behind it and how do we improve rural primary health care in Africa. So let me stop there and just check on a few things. We just want to make sure we have our translation. I think we've been stood up perhaps. So I'm sorry about the English French translation. If you are, please accept my apologies. But nonetheless, great to have everyone on board. I don't think we have anyone missing that isn't panelists yet. So let's start then with Bruce Chater. Bruce, I think there's been lots of very useful information that he's provided. He's CVs on the page, and I think we're very pleased. Sorry, give me a second. So in terms of Bruce, Bruce is basically the chair of the Wonka Working Party on Rural Practice, is also a professor in the main academy of rural and remote medicine in the University of Queensland, immediate past chair, statewide rural and remote clinical network, and Department of Health, Queensland, and medical superintendent with the right to private practice. Theodore and medical director. I'm afraid, Bruce, I didn't quite get all the details. I stole it from his signature. So apologies if I got some of that all wrong. But nonetheless, I can just tell you that Bruce is a wonderful person. That's probably his lead introduction, but a very accomplished family physician. Over to you, Bruce. Tell us about what goes on globally around rural health issues. And over to you. Thanks, Bruce.
Thanks, Shabir. It's a pleasure to be with you. And I'm just going to share my screen and hopefully you can see that, and I'll go up to the presentation mode. So
you can see it.
Excellent. So thanks very much, and I'll try and do a quick run through a few things that I think are important with respect to rural issues in primary healthcare. And I'm a doctor in a rural area in Australia. It's obviously quite different from some other rural areas, but most of the problems are the same, just in different dimensions. So I wanted to tease out as Wonka, rural Wonka, the World Organization of Family Practitioners, just what we see as the issues. And I think the issues are shared right across the teams in rural, obviously once again in different dimensions, but very much the same sort of issues. This is in association with our 18th World Rural Health Conference, and you're welcome certainly to join Innocent and his team and Jane from the Association of Family Physicians of Uganda, who've been assisting us with that. We're very, very pleased to be in partnership on this occasion with AfroPHC, and also very pleased in our webinar series to be in partnership with WHO about rural health equity. So I think there's some wonderful opportunities to collaborate. The conference theme is about universal health coverage, and obviously looking there at the map of universal health coverage, Africa is an area where we need to work with you guys to see if we can improve that, because I think that's absolutely vital to rural areas. Rural Wonka has been around for a while. This is one of our meetings when we used to meet face-to-face before we went on to all these video links. And we've got a number of things that have happened in Rural Wonka that you might like to know about. We've got a ruralwonka.org website with lots of resources about our policies. We're very pleased to be in collaboration with AfroPHC. As I said, on this occasion, we've had a lovely collaboration last year with Towards Unity for Health, Network Towards Unity for Health. We've got our young doctors group, Rural Seeds, and they drive a lot of our agenda beautifully along with respect to the next generation. And we've got a rural medical education guidebook, which you'll see the chapters of on our Rural Wonka resources page. We've been around for a long time, and so is rural healthcare as an issue. 1982, this is a book by Rosenblatt and Muscovise, and their principles of healthcare are pretty stark and very much the same these days. And you'll see some of those principles come out in what we're talking about tonight. On our website, you'll find copies of our policies. Training for rural general practice was our first one, and then rural practice and rural health. And a lot of the ideas, a lot of the initiatives that have come through Rural Wonka have come from those policies and through those policies. And they've been very much influencing the WHO guidelines, which are now out, about health workforce development, attraction, recruitment, retention in rural remote areas. And I'd certainly encourage you to have a look at that document on the web on WHO. So this last year with Zakir, you'll see Zakir Rahman, who's with us tonight. Zakir pivoted very beautifully actually to run a virtual conference in Bangladesh last year, and we do sincerely thank him for that, and we do hope that it has helped his cause in Bangladesh, as well as obviously inform our thinking about lower and middle income countries. So we from that developed a blueprint for rural health, and as you can see, it's there. There's the link to the blueprint, and I think Zakir very kindly put it out in the pre-reading. But we did acknowledge in there that Bangladesh had gone a long way towards improvement in rural health, particularly with the community health centres, and those community clinics, community health centres, trying to get care closer to home, which is a big part for us about rural health. I live in a rural area, and the things that are important to me in my community and for my personal care, in fact, is primary health care. But in rural, primary health care's got a slightly broader concept. It is first contact care, it's local, it's comprehensive, it's grounded and proactive. But it needs to include not only prevention and public health, it needs to have family practice, it needs to have nursing practice, it needs to have Aboriginal health workers as we have them in Australia, community health workers elsewhere. It needs to provide some emergency skills, it needs some advanced skills, and it needs even in some places, inpatient care, so in small facilities, to have that ability to look after patients in those environments. And it needs the diagnostic processes as well. So primary healthcare is often seen as somewhat the poor cousin of secondary care and tertiary care. I think we should recognize that it's much more than that. And it certainly needs to have, in rural, the ability to provide comprehensive care. The key principles and concepts in our blueprint were around the need for advocacy, as I said, primary health care, universal health care, universal coverage, which we've talked about very briefly before. We need the public health and community infrastructure. Access is everything in rural areas. It's about being able to be within walking distance or better, driving distance if possible. But I know in Zakir's area in Bangladesh, there was a whole emphasis on that sort of hour or so access to try and get to a community centre. And it needs workforce, and I'll talk a little bit about workforce. We've talked a bit about universal health care, and that needs to have, once again, the access, the affordability, the gender equity. It needs to be culturally appropriate. And for many communities around the world, obviously the most disadvantaged can be those that are in the Indigenous population, and being culturally appropriate to them, whether it's in Africa, in Australia, in Canada, or in India. It's a real, it has to be a priority, I think. It needs to be engaged and local, so it needs those local solutions, comprehensive solutions, and very much around the infrastructure as well. Not only health, but all the other infrastructure about education, employment, housing, clean water, sanitation, sustainable energy. And I think obviously that's a major issue for many countries. I want to just talk a little bit about how we look at workforce, and particularly the next generation. And I liked this quote recently about the medical workforce you create is the health system you get. And so I think it is important to recognise that it needs to be an appropriate workforce. And in some areas that will be community health workers, hopefully properly supported. In some areas that will be nurses, hopefully properly supported. In some areas that will be teams of community health workers, nurses, doctors, hopefully appropriately supported. So we need to try and look at what are the ways that we can get that workforce into rural areas. There are a few important concepts that have actually come to the fore over recent times, and these are just some of them, and I'll be touching on a few. But I think there is a need for that pathway, that end-to-end planning and integrity. Is a thing called clinical courage. I'd encourage you to have a look at that. It's been published in the British Medical Journal about the need for doctors, health workers, and others in rural communities to be able to step up and be courageous about helping their communities. It's about education in rural for rural. It's about community engaged education, and it's the immersive part of that that's important. It's about getting some exposure, growing your own workforce, and I think that's probably one of the most important parts, is to have people who want to be there. We need some redundancy. We need some spare hands around. There's concepts of step ladder education. We need to engage young doctors. We need the right health workers in the right spots. I'll talk a little bit about rural generalism, rural origin, ruralization, and obviously this needs to be in a whole overall concept of rural policy and rural proofing. And we need to have that localizing economic benefit. We've seen where there have been good education initiatives that does have enormous benefit for the communities. So you cannot be what you cannot see. And these are just some pictures from some of our local simulations and things. But everyone needs to be able to see where they're going in their careers. And I think that applies particularly in rural areas. They need to be able to understand rural culture, sensitized to that. And the best way to do that is to have the exposure. I think, and we put in the blueprint, that the proportion of students with rural backgrounds coming into health science courses should be at least equal to the rural-urban ratio. And then you need to get them back out into rural areas. Sometimes for those that come from urban areas, there's a pathway, and I like this document with this diagram about how you prepare them, how you give them the rural experience, how you socialize them. But there are things that will make them positive, and you'll see on that right-hand side, the teamwork, the accommodation, the practical experience can be very positive and make them satisfied. Whereas difficult financial stuff, difficult internet, difficult living environments can make things worse. Roger Strass has been talking about, and I'll come to it on the next slide, about immersive community engaged education. And it's about students spending more time in rural areas. It's more than just teaching, it's actually learning in rural areas. And with the internet these days, there's no reason why you can't learn by living in and then using the environment to learn the larger set of skills. You've got the internet. There are lots of resources now that allow you to learn in situ. And it's part of, as I said, a discussion paper by the World Bank recently. And I think it's a great one. I'd encourage you all to read it. It's by the two Strasses, Roger and Sarah. And it's just shown that learning in these environments can provide a very rich, patient-centered, practical learning environment on which academic learning can be scaffolded. So I'd encourage you, as I said, to have a look at that. There's lots of things the World Bank have also identified at times about constraints to the labour market, particularly in rural areas. And I won't go through these in any great detail, but it obviously does affect patient care. And this is one from a previous Africa Health Forum in 2013, which I found summarised some of the important things there about making sure that there are proper incentives and supports. Why is it important? Obviously, the health worker density changes the type of service that people can expect, and we should be giving our rural people their service that they do need. I thought this was a fascinating part of that article, and that's that the incentive is not just the financial incentive. That black line is the financial incentive. But what happened when people were actually given some supervision, given some basic housing, given some superior housing, given better equipment? As you can see, the dollar amount that's needed, in fact, to get people, the wage bonus to get people into rural areas, moves to the left. It's a dose response curve, just like any other dose response curve. And I think we need to encourage our policymakers to recognise that it's about the lived experience, not just the financial side of things, although, once again, that is important and people need due recognition. I'd like to just finish off with some discussion around rural journalism. As rural doctors, we feel, and rural family physicians, we recognise that all of us need to work very broadly to our full scope of practice, whether that's nurses, community health workers, doctors, or others. And that's the whole concept of in the area of medicine, the Cairns Consensus Statement on Rural Generalist Medicine. I won't dwell on that, but I would encourage you to have a look at that. And there are a couple of key elements there, which is around comprehensive care, inpatient care, emergency care, extended care, population health, and working in multidisciplinary teams. So I think that's some of the concepts that we're emphasising in rural as something that will help solve the rural crisis. It's not an easy one, but there are some things that I think those exposures, that broad range of practice, and the appropriate incentives and environment are all important. One of the things you can do is look at we've got a checklist for implementing rural pathways. This was proudly done with WHO a couple of years ago. And here's an example of some people in Kazakhstan looking at that checklist. Where do you find the checklist? The checklist is in a number of places, but probably the easiest one to go to is on our Wonka Rural Wonka resources page, and there you'll find there's the World Rural Health Conference, and the sessions from that conference are on there. But over on the side, you'll see, if you do a quick search for the pathways, for the pathways document or the checklist, you'll see it there in a number of different languages, so that hopefully you can use that in your language. So I've tried to keep under the 20 minutes. I'm just, I think, underneath now. So I'm happy to talk further about these things in questions and in our breakouts. I've only touched on some of the elements of the blueprint, but I hope I've given you a taste of some of the things that we think are important in the future to make sure that the next generation are attracted to rural areas, rural primary healthcare in its richness and its full scope. So thanks very much, Shabir, and I'll hand back to you.
Thank you very much, Bruce. I think that was really wide. I mean, I think talking global issues of rural issues is not done in 15 minutes. But thank you for going through that and providing some really great insights and important documents. You spoke about the rural healthcare, from 1982 to the blueprint now. I've got questions, but I think let's leave those questions for later. I just want to quickly remind people that you can use the the chat place to actually add questions. You can also download Menti on the App Store. I've given you a link, and Jana particularly will use it. So if you can download it, I'm sure when she presents it, you'll see the link, the number, the code, and you can use it then. In addition to that, we've got our interpreter for French around. So if you are speaking French, please feel free to use it. Just click on the interpretation button at the bottom. So thank you. We've grown a few more attendees. Let's move on. And Bruce, thank you. I'm sure we'll get questions coming through on the chat, and then we'll take it from there. I don't want to derail the presentations. We'll take all the questions together towards the end. And thank you for being brief. The next speaker is Zakir Rahman. He's a family physician from Dhaka, Bangladesh, an associate professor of family medicine linked to Bangladesh College of General Practitioners. He's also a 5-star awardee in Wonka, South Asia this year. He's working in a rural area despite coming from Dhaka, so I think he travels every day, if not stays there. But he's also the president of the Primary and Rural Healthcare Bangladesh since 2015 and part of Rural Wonka with Bruce. So over to you, Zakir. Thank you for joining us. Really appreciate that. Assalamu alaikum.
Thanks, Sabir, for a nice introduction. And I'm very happy you are inviting me. Thanks all the organizers. So rural challenge in less developed countries, Bangladesh as example, and you're very welcome. So
Zakir, are you struggling with your presentation?
You're not seeing my screen?
Yeah, we don't see your screen. What you can do is, if you can email it to me in the meanwhile, but if you click on open the document, the slide, and then click on share screen, the green one. And then you should see the PowerPoint.
Are you see now my screen?
No, not yet. I think there's something, but it's blank. I think it might be the sharing, the sort of settings. Oh, there we are. We're getting it.
You get
I think you've got, yeah, now we see it. Thank you.
Okay, thank you. Thanks, Savi. So this is from where I am. This is Bangladesh. I'm surrounded by India, and in southwest is Bay of Bengal. We have the world longest sea beach there, and our near neighbor is Nepal, Bhutan, and China as well. So it's 8th most populous country of the world. You know, we have only 144,000 kilometer area, and we have 160 million people. So so many challenges in our health system as well. So, you know, in WHO report monitoring the health SDG goal in 2000 and 2016, we are improving the life expectancy at birth more than 7 years, and healthy life expectancy from 2000 to 2016, that is 56.3 years to 63.3 years, expectedly improved by 7 years. And nowadays it's some more. And you know, our per capita GDP is more than $1,500, and our urban population is around 35%. So still we are around 70% people lived in rural areas. So rural issue is very important there. And Bangladesh has made substantial progress over the last 2 decades. Bangladesh is a country that has seen remarkable health improvement since gaining independence in 1971, and has evolved from being a basket case to an exemplar of good health at low cost. However, still 64% of health expenditure are made out of pocket, which is very alarming. So as a result, thousands of poor households are being pushed into poverty, which we call catastrophic expenditure. Bangladesh is experiencing the highest 15%. Then India is 10 to 12, and that's very promisingly in Thailand, that is less than 2%. So challenges are improving the responsiveness, equity, quality of healthcare services, and use of IT for achieving universal healthcare. So as such, a WHO report proposes 3 interrelated health financing strategic options: raising sufficient fund for health, reducing heavy reliance on direct out-of-pocket money, reducing and eliminating inefficient and inequitable use of resources. So Bangladesh is one of the best government health infrastructure in South Asia. In addition to medical college hospital, tertiary care hospital, we have 500 Upazila health complex, around 5,000 union sub-center, and 13,000 satellite clinic, that is a very well-known community clinic for every 6,000 people in Bangladesh. So trained healthcare professionals are quite inadequate at this rural center. Those who are working there are facing resource constraint in terms of facilities and financial space. Again, for diagnosing the routine common and even in uneven case, investigation facilities are mostly unavailable and sometimes not reliable. Rates of investigation are also very high at private clinics, and there are seldom monitoring by concerned government authorities. So patients have to pay all from their pocket when getting treatment from the private sector. Poor people have difficulty with access to the government secondary or tertiary care hospital, but government have more or less free most of the things. People at low resource center will go to government health center if they get doctors, drugs, and other facilities available. We do not discourage the private health sector, but they should be quality based, compliant with the patients, need cost effective, and monitored by quality assurance cells of government. So a first observation is that simple preventive interventions were more likely to hit the universal health coverage 2030 target of 80% coverage, whereas coverage of complex one, such as institutional delivery by a skilled attendant, were marked by lower coverage and high inequalities. It follows that issues of access to and quality of complex and comprehensive intervention need increased policy attention. So by community empowerment, we can overcome most of the challenges. We mean the process by which relatively powerless people in the community work together to attain control over the events influencing their life. The term community empowerment has a tendency to be mentioned loosely, especially by the policymakers as well as the NGO movers. In several literature, community participation or involvement, social capital, community capacity, human capability, and community competence, and have been used synonymously or with a subtle distinction. One of the largest NGOs of the world, that is Bangladesh Rural Advancement Committee, BRAC. Some of you know while BRAC has been carrying out empowering activities since its inception, as well as in age of the Bangladesh. In addition to its nationwide education program, women empowerment approaches, legal aid services, and microcredit program, which is very popular, like Grameen Bank, one of the Nobel laureate from Bangladesh, that is Professor Yunus. So they are like similar. BRAC has been running massive health program throughout the country in terms of primary health care, and especially in rural areas. So Bangladesh has a very successful immunization program, that is around 96% diphtheria, pertussis, tetanus, and measles vaccine, and even 94% in tetanus toxoid. So very variant in terms of South Asia. The expanded program on immunization is successfully incorporated the contribution from the NGOs, local commercial enterprises, and even community volunteers. And primary care and rural health Bangladesh also play an important role in rural areas. This inclusive nature of the EPI program is indicative of people's involvement from different spheres and eventually empowering them. Even DOTS therapy, that is very important for tuberculosis, is run by these modalities. So Bangladesh suffers from both a strategic and geographic maldistribution of human resource of health. There are an estimated more than 3 physicians per 10,000 population and more than 1 nurses per 10,000 population. Now it's a little bit more. So there is a severe gap between sanctioned and field health worker position, and 75% or more of the sanctioned staff working in the facilities. There's the study done by World Bank in the little before 2009. So now it's improving here. And 28% of treatment provided in government health facilities is through not traditional medicine, that is alternative medicine, Ayurveda, Unani, and homeopathy. And although 70% of the population lives in rural areas, major challenges include an overly centralized health system, weak governance, structure and regulatory framework, weak management, and institutional capacity in the Ministry of Health and Family Welfare. So fragmented public service delivery, inefficient allocation of public resources, lack of regulation of the private sector, which employs 58% of all physicians, shortage of human resource, high turnover and absenteeism of health workers, and poor maintenance of health facilities and medical equipment. Despite these challenges and the fact that human resource in health was not considered a priority in the current sector program. So this is very important for health worker training facilities and an increased number of rural health facilities. So universal health coverage contributes to people being more productive and active, contributes to their families and communities, especially in primary care setup. It can minimize the out-of-pocket money as health expenditure. It also ensures that children can go to school and learn. We need it because we, as well as advocacy, we need health-seeking behavior for proper addressing of health. Universal health coverage could transform the lives of millions of people by bringing life-saving healthcare to those who need it most. Patients at low resource center in rural and slum areas need to have a door-to-door approach. So malpractice and fraudulence by quacks and others need to be tightly controlled. Policymakers must curb the corruption in the public health sector and provide adequate facilities in terms of human resource and amenities on government healthcare. The agenda should draw on the experience of the first generation of innovation that underlie the country's impressive health achievement and creativity address future health challenges. So she is our running Prime Minister of People's Republic of Bangladesh, and very recently she receives the Sustainable Development Goal Progress Award. So congratulations to Honorable Prime Minister, and we are waiting for very active and primary care in rural setup as well as in urban for the betterment of health system in Bangladesh as well as in Asia. So thank you very much. So over to Shabi.
Thank you very much. Appreciate that, Zakir. I think I was really struck by the fact that, Bangladesh looks very similar to Africa, and that you made some really good achievements. I'd love to ask more about how that's happened, and we'll take it up later. But I think talking about your community empowerment, the BRAC, I think we really want to know more details later, and ask questions around, how your government's dealing with universal coverage, in terms of addressing the system, like you've pointed out, lots of challenges. Really appreciate that. Thanks, Zakir. I really appreciate that. Let me go to our next speaker, who is Innocent Besije. He's a family physician in Uganda, the chair of the Uganda Family Physicians Association and the president of AfroPHC. He also serves on the executive committee of Prima Famed, which is the family medicine training network in Africa, also linked to the Besru Forum in Canada. He's the co-editor of the African Journal of Family Medicine and Primary Health Care. So welcome to our president, Innocent. I think you are able to share. So let me leave it to you to share what you see as the African challenges for primary health care in rural areas. Thanks, Innocent. I'm not sure if you can share your camera, but we'll love to see you presenting in person.
Are you able to see my slides?
Yes, great. We can see you and your slides. Wonderful. Go ahead.
Yeah, thank you very much, Shabir, for the kind introduction. And I don't think there is anything else I needed to add in the interest of time. And I will briefly talk about the rural African challenges for primary health care. I thought I should begin with highlighting some of the special issues in Africa that actually makes these challenges, that amplifies the challenges that we face in the rural PHC. Because what I'm going to talk about happens in most other regions of the world. But in Africa, their effects are quite amplified because of these issues. So one of them is that in Africa, we actually have the highest global burden of disease. Unfortunately, we have the lowest level of healthcare workforce. So you have much disease, but less healthcare workers. And you also know that in Africa suffers high prevalence of poverty. So we have high poverty levels in most of the countries. But also the literacy levels are quite low at the global scale. And all of that, in a way, coexists with the weak health systems that are not able to withstand crises. So what are some of these challenges that are facing rural PHC? Really, we know that where there are no health workers, then there is no health care. It doesn't matter whatever else is in existence. You may have better financing, you may have better infrastructure, but as long as we don't have a good workforce, then we are really not going to achieve universal health coverage, which is the vision for primary health care. So what are these primary health care workforce challenges? One is that they are really few. So we really don't have enough PHC workers. For example, in Uganda, where I am, our staffing levels in the primary healthcare facilities is always less than 50%. And because of that, it becomes very difficult to really offer primary healthcare. But looking again at what we are talking about, these low levels of primary healthcare workers exist in all of the areas, but the situation is worse in the rural areas because for some of the reasons that are well known, lack of amenities, lack of other requirements. For example, the PHC workers are going to run away from the rural areas because we don't have schools, people do not have recreation facilities and other things. So, and that happens alongside the poverty enumeration. What happens is that we always hear constant strikes in most places where health workers are actually struggling, are complaining to the governments for pay rise. And here I really want to mention that in most African countries, we use community health workers. What is absurd is that in most countries, these community health workers they play a voluntary role, so they don't actually get any payment. And we really don't have support for these PHC workers. And by support, I mean, in terms of training, you find somebody is a nurse or a midwife in a rural area for 10, 20 years and has never received any further training. That quite demoralizes them, in addition to actually having a depreciation in their knowledge and skills level. And I here also want to mention that the same thing happened, that even the support for rural health care is not available in most of the medical schools. When you look at the curricula of various medical schools in Africa, very few actually give significant emphasis to content concerning rural primary health care or rural practice. So the assumption is that whoever is trained and graduates out of medical school should be able to meet these rural health challenges. So it's really the support even in the training is quite not adequate. And the other challenge is that most of the rural areas do not actually have equipment. You find that people are practicing, but actually they don't have supplies, they don't have medicines. In Uganda here, we have had several cases where people report that they don't even have electricity within the facility. And they are delivering mothers at night just using hand torches. So we really need to, this is quite common, that yes, we know that we don't have adequate supply of essential medicines and equipment across countries, but the rural areas are hit hard. The few people who are actually working in rural areas in primary health care, in many countries, they are not organized in teams. So you find you have one person or two running a facility, and then they are just struggling. And it's not unusual that in some facilities in the rural areas, they even co-opt people who have never had any training, for example, security guards to assist in dispensing. We have found this. It's quite absurd, but it does happen. And when we actually don't have teamwork, these primary health care workers get exhausted, they lose the morale, and sometimes they suffer burnout. And as a result, they are likely to actually run away from these rural areas. Now, we also have problems with geographical challenges, as it is a well-known fact that most rural areas are actually geographically isolated. So, and these geographical isolations will actually make movement of both patients and health workers quite difficult. So you find the population or the communities is not able to receive care because of difficulties with the movement. And sometimes the health workers also have difficulty navigating across the bad terrains. For example, that picture on the left is of a friend of mine who works in a rural area in Rwanda, and you can see the footpath he's using. It's very difficult for the doctor to stay for long in such an environment where, despite even having a car, but he has to actually move on foot. And you also have to remember some of the isolated areas we have, for example, here in East Africa, the Great Lakes region, but also in other areas where there are swamps and rivers. These places are quite isolated. And for example, we need to pay attention to rural health care for island areas. You find people in the island, they have no way how to cross over to the mainland to access care. And sometimes there is only one ferry or one boat. And if an emergency happens, then the person is not able to access the services. So we really need to be cognizant of these mountainous areas which make certain which actually cuts off certain populations from the services. And I think, as I mentioned before, because of our weak of our levels of literacy and other problems, we also have weak technologies. Really, in Africa, we may say these technologies are appropriate for us, but the truth of the matter is they are really quite weak. For example, you see those people are using a tippet tap for hand washing. Sometimes you wonder how long it stays. And we may say that they are using local available materials, but they need the time and the energy, and sometimes some money to put them up. So because of these weak technologies, it's sometimes very difficult to sustain for comprehensive primary health care, particularly in the rural areas. And we know that PHC is really encompasses quite a lot of things, including the food security and the proper nutrition. But for example, you find in many African communities, people are still using the hand hoe, which actually puts food security at a risk, that people are not able to really use these weak technologies for sustainable supply of food to the communities for proper nutrition. And we know that in Africa, one of the challenges we are facing, despite not being one of the contributors of the carbon footprint that is really driving climate change, but we know that Africa is really struggling with the climate change, and it is not unusual to really suffer floods, to suffer landslides, hurricanes. You know what happened in Mozambique a couple of years ago. We suffer a lot of drought, and these disasters actually cause damage to the infrastructure, and it is not quite easy to put it up again once there's damage. For example, that picture on my left is one of the hospitals in the Western Uganda was actually washed away by floods, and the health services have not recovered, and it has actually happened twice. Yeah, it's still really problematic. The landslides really cut off road networks, and the patients have nowhere to pass. So we know that these things also happen elsewhere, but in Africa, because of our unique problems, which I talked about, we are really less resilient to the effects of climate change, and we know that that is a very serious threat for rural health care. And we also don't have to forget that food is really key. Everyone must survive on food. There is no one who survives without food. And these climate changes are really putting PHC in a very terrible situation, because the food supply is under threat, particularly because of droughts, floods, and other natural disasters. Now, last but not least, but which is the elephant in the room, is actually leadership challenges. In Africa, we are really faced, in many countries, we have leaders who do not have a commitment to primary health care. More so, they are not cognizant, and they really don't put into consideration the unique challenges of rural health. They tend to use a blanket approach where they think that everything, whatever they decide, fits everyone else. And I think leadership is important in reorienting our PHC efforts to improving rural primary health care. But also, most of our leaders really are not transparent, and they lack accountability. And the rural communities, because of the unique issues of illiteracy and lack of information, sometimes do not hold these leaders accountable for better health services. And the challenge is that we have political commitment, but with no political action, where actually we think that there is a community participation, but the people whom we are deciding for, whom we think they are actually participating in the planning, design, and implementation of health services are not on the discussion table. So really, leadership is quite challenging, and I think if we are to get everything else, we need to focus on having accountable leadership that puts into consideration the unique challenges of rural primary health care. Thank you very much.
No, thank you very much, Innocent. Great stuff. I think very useful insights around healthcare workforce and the contextual challenges, as well as this country leadership challenge that we have in Africa. I think there are lots of issues we can talk about later, and I think pull the threads together amongst the various speakers. Before we do that, let's let Jana Muller speak. Let me quickly introduce Jana. Jana is an academic coordinator at Ukwanda Center for Rural Health, which is in Stellenbosch in South Africa. She works there with a focus on interprofessional education and collaborative care. involved in student facilitation, community engagement. It's a rural setting, and she's been there since 2011. And Bildi assisting also with the expansion of training in Yuppington, which is in the Northern Cape. She's a physiotherapist by profession, but has the specific interest that she's going to share with us. Over to Jana. Thank you very much for joining us. Really appreciate you sharing. And let's let you have a few minutes. I want to do a poll of all those who are here. So I think before we, as we start the question time, we'll do that. Thank you very much, Jana. Over to you.
Perfect. Thank you very much, Prof. Musa, and thank you for the opportunity to connect with colleagues from AfroPHC. So some of the questions that I might ask during this presentation might be duplicated in the poll afterwards, but we can have a look. So I've been tasked with talking to you about team challenges to rural primary healthcare. And the irony is, although there are lots of experts in team challenges in rural primary healthcare across the globe, I think the people who know best are those who work on the ground. And I can only speak to specifics of the place where we engage with our student learning in South Africa, but realizing that you all being here as individuals working at your own clinics are the experts in the challenges that you're facing. But I think just to reflect again, and I think this has been something that's been reflected on already, but Prof. Cooper, my boss, always presents this, and I think it's a really useful way of looking at the difference between rural and urban, that it's not just a geographical concept, that it is difficult and slippery. I think what Prof. Basier just now presented to us was really one of those hits you in the chest, kind of how are we going to manage this reality of how difficult rural can be. But it's also got its beauty. And I think, you know, working rural and advocating for rural education and wanting there to be rural pathways, there's this reality of, although rural is complex, it's truly very beautiful. And there is, with that, hope. So the notion of rural extends beyond the geographic. And I think this is something that Prof. Or Bernard Geder wrote recently in an article about the medical doctor reconsidering their position in the healthcare team, primary healthcare team, also talks to looking beyond just how hard it is to get to rural places. But it's a very soul culture and language and tradition. So everyone's rural primary healthcare picture looks different. I think we have definitely had some during the presentations prior to mine, looking at each country has their own rural population, but they also have their own government's commitment to care in those rural primary healthcare settings, or just in primary healthcare in general. But then also looking at primary healthcare teams across Africa, they're very, very different. And you know, looking down to the very, very home-based teams, every country has a different strategy and a different policy. In fact, sometimes I get lost in our own country's policies in keeping up with what's happening in the different provinces. And I think that's a reality, is to realize that although we're clinicians or educators, there is an overarching policy that, for whichever reason has been decided on, that needs to be put into governance. So just looking at the human resources for health, which we know is one of the biggest challenges. Again, these are country specific. There are ideals for what is available at certain primary healthcare institutions, and all of us know that it is very rare for there to be a complete team in a rural setting, for many of the reasons that Prof. Basier has mentioned above. But the challenges of, you know, a population of 10,000 having to deal with 0.1 pharmacists is a reality we all know too well. And then the number of physicians that are available to our patients in various countries is sometimes incredibly alarming and very hard for people from the West to really comprehend. And I think this is specifically looking at our primary healthcare population. So the challenges, we know: access, geography, culture, hierarchy. There are too many guidelines, and we feel like there's too many guidelines, often issues with leadership, human resources, and all of these issues get into the way of there being appropriate teamwork, which helps, we know, with patient management. You know, there's a lack of cohesion in groups, not including patients and their families. So I would like to just do a Mentimeter poll with you for a second. And I'm just going to give you the code for that. Share a new screen with you.
I can share it as well. I've got it up.
Oh, have you got it up? Right.
Okay. So if you're on Mentimeter, you should see it now. Your code, do you want to tell me the code?
Yes, I will. It is 9616.
9616.
1963.
1963. Okay, I'll copy that, paste it into the chat, and you can all add in.
Okay, and I'm going to share my screen with the actual questions.
Sorry.
Okay.
There's the code. All right, thanks, Jana.
Yep. The correct questions are being asked.
I think it's somehow not allowing me to go in for some reason. All right.
Is anybody able to access this?
I basically add my question, so yeah, I've added mine in, so it should have responded. It's, yeah, I think you've got people now putting themselves up.
Let's stop sharing and see what.
Okay, let me just also do a poll. So while you're doing it, those who are on thing can just quickly fill this in so we get a sense of where you are from Africa and also what your background is. I'm not sure that you're going to go to that as well, but some people may not have gotten onto Menti, and they can just quickly add this as well. Can you just quickly add this in as well? Can we move on to the next question as well for you, Jana?
Okay, so that was what level of care do you work at?
Okay.
And then
okay, so reviewed and voting time.
Okay. The following question that should come up in Mentimeter is, which professions do you have in your primary healthcare team? So for those of you who are connected to Mentimeter, you could just list those. For those of you who aren't connected to Mentimeter, it's, I think, an important reflection to consider who's in your primary healthcare team or who you consider to be part of your primary healthcare team. At the moment, we have none, and then also a nurse educator who's part of the healthcare team.
Okay, I'll just share the poll results for those who are interested. 20 people responded, so it gives a sense of some of the other questions you might not have asked it.
Excellent.
So.
Great. That's great. It was the first two questions on mine, so that is actually perfect. Okay, so the other profession we have on one of the teams is basic life support on the primary healthcare team. Care workers, nurse, clinical associates, students, doctors, family physicians, nurse, midwife, community, doctors, physios. Great. So there are some teams that are very, very sparse. In fact, none, no teams, and other teams which are quite comprehensive. The next question is, waiting for it to come up. Let me just see why I didn't. Okay. We'll come to the last question just now. So what I'd like to do now is to go through sorry, I'm jumping around from place to place, but I'd like to go through a case study with you, which is not going to be unusual to anybody. It's going to be a case study which I think most people already know about because you've seen this 100 times before. It's a 49-year-old female coming into emergency center at a secondary level hospital, some 50 kilometers away from her home, presenting with a right-sided weakness of her upper and lower limb. Her previous data in her file said a previous TIA was sustained a year prior to that, and that she was an ethanol abuser. The patient was seen in emergency medicine, and ideally the patient would have been admitted into the ward to be stabilized and put on medication because she wasn't yet on anything, and provided with an assistive device before being set up for discharge, including ambulance or patient transport back into her community, and then with the chance to connect back with her family and be followed up at the local primary healthcare clinic. From the local primary healthcare clinic, follow-up from community healthcare workers is usually idealized, and then support ongoing from local healthcare workers in the community. We also know, though, that the challenges, especially where we work, is there's a very big divide between the secondary level or provincial level hospitals and the primary healthcare institutions, where there's not necessarily a very good communication between them, and not necessarily always a very good referral process between them. So if this was the patient, we would imagine that there's a community care worker involved, a nurse, the rural doctor, pharmacist from the hospital and the local clinic, a dietitian, speech, language, and hearing therapy for this patient who suffered a stroke, mental health support, very young individual who's lost her function, physiotherapy, social worker in terms of disability grant access, but also support for the family and support for the younger children of this mother, occupational therapy. So ideally, we would imagine that the team would be quite comprehensive. In this case, which is actually a case I had with my students recently this week, that same patient came into the ER with right-sided weakness, not on any previous medication. The patient went straight to ER, was seen by the doctor who stabilized the patient, ordered a CT scan, and discharged the patient with aspirin for a week with a discharge summary, and was told to follow up at the clinic to get medication a week later. The patient waited outside for about 5 hours before somebody was able to offer her a lift, and she was taken back to her kilometers away. It was there that she was able to reconnect with her family, who had no insight into her diagnosis or understanding the processes behind what needed to happen next, except the garbled speech of the patient in terms of when she needs to follow up and the discharge summary received in the envelope. By word of mouth, 2 weeks later, the local community healthcare worker heard about this patient via friends, since community healthcare workers are often resident in the communities where they work. And the community healthcare worker went past the house and identified this patient. There was no access to long-term medical care. There was no issuing of any assisted devices, and therefore there was no transport or ability for the patient to follow up at a primary healthcare level at all. So the patient was not able to get to the clinic. So from a comprehensive team, we often sit with patients who then come to the primary healthcare setting, who were just at a center with all of the resources and all of the staff, but they were not able to tap into the skills that those staff members often get discharged too soon or bypass care sometimes or immediately. And so this particular patient only had access to an ER doctor, pharmacist at the hospital, community healthcare worker, and a nurse. So realizing that our pool suddenly becomes quite small if there's not very good insight from a secondary or provincial level care down into how primary healthcare really works and the challenges we sit with at a primary healthcare level. So I want to get an understanding of what primary health care teams face in terms of the audience that we've got. I do think it might be easier, for the sake of time, to just type it in the chat. So I'm going to force you to please respond, and in the chat type in what challenges your primary healthcare teams face specific to your team, And if you're working at a provincial or secondary level hospital, which is perhaps better resourced, what is it that frustrates you about the primary healthcare team? Everybody has something to say about primary healthcare teams. So I would appreciate some insight into your experiences. I've already shared some of them with you. Come on, you guys are like students. It's awful. Nobody's saying anything. There we go. So management interference. Yes. So this is, thank you very much, Prof. Musa. I think that's a very good point. So again, also good teamwork sort of being interfered with by policy being verticalized, so sort of dictated and not necessarily being a good concept or even an understandable concept of how to put that into practice. I've gotten some private messages, mistakenly perhaps, but signal connectivity, absolutely. Transport, distance to care, language barriers, governance, funding, capacity, and gaps. So these are all things that have come up now with Prof. Besiye and our other speakers today. What I would like to talk about now is, so that we've also got no implementation of population, I think, to team, leadership gaps, limited human resources. My frustration is with motivation and incentives. The care workers are volunteers and government is not even thinking about paying them. How many times have we heard this? And I want to talk specifically to that. The lack of intersectoral collaboration. So I think just the most important thing that's been raised here is the value of our community healthcare workers, and how we saw in a few slides previous to this, how the fundamental basis of the home clinic to home team is our community healthcare workers and the nurses. And yet how often are they actually included in what we define as our primary healthcare team? So in a recent publication in Frontiers, and I know this is an international, these are international authors, but I thought it was quite a succinct way of defining the most common challenges: accountability, conflict management, decision-making, reflecting on progress, and coaching. But again, we know all of these things. So what are we going to do about it? What can we do about it? I hope my Zoom bar isn't in the way of the text, but these are basically suggestions that we have from the literature, predominantly South African literature, which is absolutely fantastic. Some brilliant African literature about how do we improve primary healthcare teams. So getting orientated and staying connected, and that means living and working and knowing the place where you are. And through that, getting to know your patient through continuity of care. So almost like a doctor, perhaps getting adopted by a clinic throughout the year instead of always rotating through different clinics. Getting to know the community, residing in that community, understanding the health and social system, not just the healthcare system, because our patients are also social beings. Obviously knowing your tools, but realizing who your team is and what tools they bring. And that's not necessarily just the traditional team of physio, OT, but really who are the NGOs that you can tap into? What kind of advocacy campaigns are going that you can tap into in terms of getting access to medication at your local clinic? Your team in a primary healthcare setting can actually be so extensive if you know who you are, where you're at, and what people can offer. And I think that's the whole thing about being situated at a place for an extended period of time, which also then enables you to know what your support system is in terms of capacity development for local care workers, or perhaps even rural training pathways development and skills development. So this is a wordy, I'm not going to go through this, but it was a very nice article by Knox et al., which I will send to Prof. Musa, and it really looks at highly functioning primary healthcare teams. It's the stability of a team, the co-location, drinking tea together. I know there's no time for that, but it's actually to the betterment of your patient. Don't quote that to your boss, but it really is worth doing. Sharing the care. If you don't sit with somebody to know what they can offer, you won't be able to refer with them. You won't know what their roles are. You won't be able to set up standing orders for how would we do this next time, because this time it really didn't work. I love the idea of workflow mapping. It's one of the most crucial things, not just for the patients who come in, but also for the patients, for the people who work at the site. So the challenge that we have, and I think especially from the perspective where I'm sitting in rural health professions education, is both rural communities and medical schools face the challenges of having to improve quality, but also equity, relevance, and effectiveness in the way we deliver our healthcare. There needs to be a match now between the healthcare needs and societal priorities. And that's going to be different for every setting. And it's not necessarily easy to dictate from one place to the rest of the country. Then redefining the roles of our health professionals in rural spaces, understanding that every rural space requires a different team, a different way of working, and allowing for that, negotiating for that, working together to define those. And then to provide evidence of impact on people's health status in the rural areas, so that we can also motivate for skills development, which does need to be broadened. I think in Geda's article, he also speaks about it's not just about clinical skills. We're really looking at how do teams function? How does one really communicate? I mean, how do you build a relationship? So we know that we need more professionals. We know that they can't just be the same, but we also know that our primary healthcare sort of policy and infrastructure needs to allow for more team members to come on board. And that does take finance and leadership. We are motivated to train rural because we've seen that, and I think this is wonderful. So Prof. Charter spoke about it earlier, but training rural so that people will stay rural, and the effects that training rural has on the existing workforce that works there, the influence that the students have on the people who are already on the ground helping patients, that there's educational advantages, not just for our students, but also for the staff who work at the clinic, and also for our community healthcare worker staff. There's a reciprocal learning that happens, and that there's impact on the health service. And there's a lot of evidence that's coming out now that there's a large impact that can be made by training students in rural areas and also primary healthcare. So the nature of learning in a rural primary healthcare environment specifically is person-centered. It allows them to be immersed in a community for an extended period of time and really get to know about cultural challenges, language barriers, cultural barriers, and then try to navigate ways around that. Because of course there's a barrier, but there has to be a way to find a solution. And then the duration of time that they spend in the rural primary healthcare context gives them time to develop relationships. And that's not just between them and their patients, but also with the health system. So they understand health systems better and the challenges that come with the health system. So I work at Ekwanda Center for Rural Health, which has been ongoing now for 20 years. And our aim is to train healthcare professions who respond to health issues facing rural and underserved communities. And we train students from 5 different professional programs. So that is our allied health programs, as well as medical students. So OT, physio, human nutrition, and speech, language, and hearing therapy. And they spend extended periods of time in a local community that's peri-urban and has rural spokes. Campus, and it's predominantly in the Western Cape, but also now in the rural Northern Cape. And some of the innovations that have come out of the university's presence, but specifically the students' presence in a primary healthcare setting, and it's blown our minds at how innovative they've been in trying to find solutions to problems. But the development of after-schools programs to try and prevent drug abuse, community gardening for community nutrition, interprofessional home visits, creating rehab services that are student-run from a local container, being able to provide chronic patient management and medical distribution from a local container in a community, being able to connect with patients via WhatsApp video calls, using the community healthcare worker as a door-to-door person so that they can follow up with patients. And then also, amazingly, the students have acted as a link between our primary healthcare setting and our secondary or provincial level care, where I spoke about earlier, the hospital and the clinic, that the students, because they traverse both are allowing for there to be communication across those, which has actually been one of the most valuable lessons that we've been able to take away. And then in rural training pathway development, so the establishment of new programs, postgraduate programs that Ekwanda is now starting, the development of training packages for community care workers at the local clinics. So an example really just of a team of students visiting patients' homes with one community healthcare worker on foot. This is older data. There's a recent article that we published this year, Ian and I, but looking at just going door to door and asking questions about biopsychosocial spiritual. So really using a framework to look at the family. There were 200 homes that were visited, and in those homes, and this is a community 5 kilometers away from the local hospital, there were 270 problems that were actively identified. Household members who had issues that were identified, and 522 of these needed to be referred. So the types of problems aren't really relevant to this audience, but what I wanted to just bring up is that they were chronic disease related. And the most valuable for me was understanding that the referrals that were actually made to student projects that they developed in the community, but also to local NGOs, because we know that the health system is overburdened in many communities. We know that the health human resources are not as good as we want them to be. So how do we broaden our team? How do we make our circle bigger so that we can reach our patients' needs? So looking at the predominant number of referrals were made to student-led initiatives and local NGOs, with only 6% of the referrals being to the primary healthcare clinic because they were not able to cope with the load. So thinking of the students and the NGOs as part of your primary healthcare team can broaden your reach. So this case that I told you about just now, this woman who left ER the day she arrived, she did go home and the care worker picked her up. We thought her care would end there, but the community healthcare worker knows us well and picked up the phone and contacted a student and just said, listen, I don't know what to do. So the students huddled around in their interprofessional group, a whole lot of different professions, and they're like, what now? So what happened is this, and this is now on Monday's presentation, the students were able to work with the community healthcare worker, a clinical pharmacy student who was joining us online from a completely different university, to get this patient referred to the local clinic, to see the rural doctor, or to see the primary healthcare doctor, with the help of a neighbor who would agree to take the patient there, with the help of his sons, because they needed to lift the patient up into Bucky, so that a physio student at the time could then also issue a wheelchair, so that the patient would then have the ability to reach further appointments and collect medication, as well as be able to reach rehab services from the local clinic. So our students in occupational therapy, speech therapy, physiotherapy, and human nutrition did a home visit where they were able to guide the family, give some information, and also refer appropriately to the clinic, so that the OT and the physio, who were part of the primary healthcare team originally, would then know how to work further with the patient, because there would be context from the home. So again, the circle gets bigger and bigger and bigger. And I think that's one of the most valuable things about primary healthcare, is we are not alone, and we feel alone, but the team is actually so enormous. So the implications is there's reciprocal learning. If you're going to have students in a primary healthcare community, their feet on the ground, they come up with such innovative ideas. And if you have students who are in your community, they stay in your community. It's that thing of sustainability and real engagement, where the university is invested in a community. So the idea would be that students stay there. If they're going to start there, they stay. And it allows for intersectoral collaboration, and also the identification of unaddressed primary healthcare issues, because students, again, are feet on the ground. So it needs to be a long-term relationship. There needs to be an investment and mutual respect. So these are some of the outcomes of rural training. We have presented this already during the WONCA, or the World Rural Health Conference, which was held in Bangladesh. So the slides are available on their website. But I want to ask what interventions you can think of implementing where you work. So that is...
I suggest, Jana, sorry, we're running out of time. So we'll leave some of these questions for the group work.
For the discussion.
Yeah,
yes,
that's fine.
That's perfect. So that would be for the discussion. And basically the ultimate is relationships, communication, collaboration, and connection. So being able to discuss that in your small groups of how do you reach those objectives as part of your primary healthcare team. Thank you very much for your time. I hope that you would consider connecting with AfriPen, which is a way to expand your primary healthcare team as well.
Wonderful, wonderful. Thank you very much. I think, Jana, I think you stressed the importance of teamwork. I really am eager to look at that Knox article. I think the idea of team construction, how we do that, and skills mix, I think those are very important, interesting questions. And AfroPHC, we've said really the team needs to come together. Everybody deserves a place in the team, but I think how you mix that together is going to be a key question. And I think the value of community health workers is very important. And where I work in Shawelo, we in fact have got community health workers who are the front and center, of the whole practice through a system of empanelment, which is what I meant by, linking a team to a population, and community health workers is a very vital part of that. So thanks you. I think there are going to be lots of questions. I hope that if any of you have questions, please put it down. We've got Professor Rokia Sanoho. I was not sure whether she'd join us, but really I'm pleased that she has. And, even if she doesn't have any slides, I think what she's going to talk about is really vitally important. And that is the question of traditional healers and their role in African primary health care, and how we can find ways to work with it. So Rokia Sanoho is a pharmacologist with a PhD, working in Titulaire des Universités, and I think this is in Mali, in Bamako, and she's working in Department Médecine Traditionnelle. So I think she's a senior, if I'm not mistaken, chef department. So I'm assuming the head of the department. But we also have French translation. So if, Rokia, you prefer French, you can actually speak in French. And everybody, if you are, if she's speaking French, please go to your interpretation and switch English on, and you'll get an interpretation in English for you. So Rokia, if you feel you want to translate, you want to speak in French, feel free to do that. So just to remind everybody, at the bottom of your screen, if you scroll along, you'll see, if you find more, you'll see that you can have a translation, and click on that, choose English. Those who want French will click on French. And if you get English, you'll be able to get French translation. Rokia, you're able to unmute yourself. Do you need any assistance? If you could show your picture, if you've got the bandwidth.
Bon, I want to know if I present now.
Yes, you can. And if you want to share slides, we'll have to keep it short because we're running out of time. Do you want to present slides, Rokia?
Oui, j'ai le partage de diapo. Oui.
Okay, I've got English. I'm wondering whether I'm getting the
Je partage des diapos, mais je l'aurai en français.
Rokia, you can share the screen.
Okay. Okay,
Wonderful.
just a moment.
Slides in French will be a challenge, but I think if she can speak in French, it's fine. Let's let her give it the chance. So she can actually share.
Okay.
You can share.
Well,
and Alexandra, if you don't mind just helping her to share her screen, and I think we'll hear the English translation, what she says. Please note time though.
Oui, vous avez vu? Est-ce que vous voyez?
If you can just, Rokia, if I may just stop you, please, you'll have to choose out of the 43.
Est-ce que vous voyez mon écran?
Sorry, Rokia. You've got 43 slides. You're going to have to keep it down to 5 or 10. Alexandra, if you could just assist her with that.
Voilà, merci.
All right. 10 minutes.
L'anglais. OK. Bon, on va aller doucement. Merci beaucoup. Voilà. Donc, je vais aller directement pour gagner du temps. Donc, c'est en introduction. On dit les ressources de la médecine traditionnelle constituent le premier recours pour les soins de santé primaire. Et les praticiens de la médecine traditionnelle sont des leaders communautaires et ils sont conservateurs du savoir traditionnel médical et innovateurs. Et la majorité des traitements, c'est sur les plantes médicinales. Et nous pensons que l'amélioration de la santé des populations nécessite l'utilisation de toutes les ressources efficaces, disponibles, accessibles, acceptables et financièrement abordables. Aujourd'hui, il existe beaucoup d'initiatives qui sont en faveur de la prise en compte des ressources de la médecine traditionnelle dans les soins de santé primaires. Et cela, non seulement l'OMS Afrique, mais également d'autres organisations, comme l'OAS, l'Organisation ouest-africaine de santé, qui a un programme médecine traditionnelle depuis 2007. Et donc, je ne rappelle pas, je rappelle juste ici les soins de santé primaire à Alma-Ata, mais la dernière Assemblée mondiale en 2019 est en faveur de la prise en compte des ressources de la médecine traditionnelle dans les systèmes de santé, dans la perspective d'une couverture sanitaire universelle. Et cela est également dans la stratégie de l'OMS 2014-2023. C'est dans ce contexte que l'OMS demande la prise en compte des pratiques médicales, des remèdes traditionnels qui ont fait la preuve de leur innocuité, de leur efficacité et qualité. Et là, on entend par l'intégration, l'accroissement des soins de santé par la mise en place d'une collaboration, d'un partenariat entre le système traditionnel et le système conventionnel. C'est ainsi le programme de l'OAS qui regroupe les 15 pays de l'Afrique de l'Ouest, la CEDEAO, a parlé de l'insuffisance de dialogue entre les deux systèmes et qu'il y a un certain nombre d'obstacles à l'intégration de la médecine traditionnelle dans les systèmes de santé. Et à travers une étude, il est ressorti que 70% à 80% de la population en Afrique de l'Ouest utilise la médecine traditionnelle pour les soins de santé primaires. Et là, il y a un cadre de concertation, de collaboration entre les praticiens de la médecine traditionnelle et les praticiens de la médecine conventionnelle dans l'espace OAS. Et le Mali, en termes d'expérience, la structure que je dirige est une structure qui a été créée depuis 1968, donc 10 ans avant Alma-Ata, pour valoriser les ressources de la médecine traditionnelle dans les soins de santé primaire. Et ce centre aujourd'hui est un centre qui a été centre collaborateur de l'OMS, mais présentement, on assure la vice-présidente du comité régional des experts de l'OMS pour la médecine traditionnelle dans la lutte contre la COVID-19. Et nous pensons qu'aujourd'hui, au niveau rural, la communauté rurale, la santé de la communauté rurale est basée par les praticiens de santé. C'est eux qui se trouvent à tous les niveaux et même au niveau des amont, nous retrouvons les praticiens de santé. C'est ainsi que nous pensons aujourd'hui qu'il est important de renforcer les systèmes locaux de santé par une prise en compte des ressources de la médecine traditionnelle, notamment les praticiens de la médecine traditionnelle, qui sont les premiers agents de santé publique au niveau rural, au niveau communautaire. Et notre objectif, c'est contribuer à l'atteinte des objectifs du développement durable, mais c'est atteindre la couverture sanitaire universelle Et chaque fois que nous parlons de ressources de la médecine traditionnelle, c'est les praticiens, c'est les pratiques et c'est les produits. Et c'est ainsi, pour le faire, il s'agit de mettre en place une organisation qui va s'occuper d'informer, d'organiser, de mobiliser les praticiens de la médecine traditionnelle, mais également d'informer, de sensibiliser et de former les agents de la médecine conventionnelle. Et là, il est important d'instaurer l'enseignement de la médecine traditionnelle dans la formation des médecins. Parce qu'on ne peut pas mettre en place la collaboration entre les deux systèmes s'il n'y a pas un dialogue, s'il n'y a pas une compréhension. Et pour le faire, nous avons adopté des approches. Et ces approches, c'est la reconnaissance du rôle des praticiens de la médecine traditionnelle pour la santé publique. L'approche, c'est la valorisation de leur rôle, c'est la recherche de solutions aux vrais problèmes, aux problèmes d'échec, c'est l'adoption des gestes qui sauvent la vie. Il faut pour nous une approche pragmatique, un mécanisme réciproque de référence de cas critiques entre les deux systèmes de soins. Parce que la majorité des patients sont au niveau rural, ils sont au niveau des villages, et le système conventionnel se trouve à des distances de ces populations. Donc, il y a lieu aujourd'hui de créer une communication autour des problèmes prioritaires de santé, mais il faut reconnaître également les limites de chaque système. Et la méthodologie recommandée, c'est l'ouverture d'esprit, c'est le respect réciproque, c'est la disponibilité à l'écoute, et c'est le courage des uns et des autres de se mettre en discussion et de reconnaître ses propres limites. Et donc, pour le faire également, il y a des expériences qui ont été menées, il faut les valoriser, il faut évaluer, il faut diffuser les bonnes pratiques. Et c'est ainsi que dans certains domaines, nous avons eu des résultats. Et je vais vous présenter juste quelques résultats. Et nous sommes ouverts au débat. Et on a fait des expériences dans la lutte contre le palu, le VIH, la tuberculose et également la lutte contre la mortalité maternelle et néonatale. Pour le paludisme, il faut reconnaître que la lutte contre le palu est basée sur les molécules issues des médecines traditionnelles, mais nous avons fait un travail d'implication du praticien de la médecine traditionnelle qui se trouve au village. Il détecte, il refait et le système conventionnel prend en charge. Il y a la possibilité de réduire la mortalité due au paludisme. Et il y a des données qui disent que la majorité des enfants au niveau rural sont soignés du paludisme avec des plantes médicinales. Et là, nous avons travaillé également à valoriser ces plantes et à mettre au point des médicaments. Des médicaments, donc des plantes ont été comparées au traitement actuel du paludisme. Et là, on a des produits aujourd'hui que nous proposons dans la liste des médicaments essentiels dans la lutte contre le paludisme. Et voilà, donc c'est les exemples que je vous présente. Vous aurez les diapos. Voilà, la tuberculose également, nous avons fait une expérience. C'est une expérience de détection rapide des cas et de référence, c'est-à-dire pour la prise en charge au niveau de la médecine conventionnelle. Parce que la tuberculose est une maladie sociale, les traitements existent, donc il est important que les praticiens de la médecine traditionnelle qui est au niveau rural puissent orienter les patients qui ont des toux rebelles vers le système conventionnel. Quand on l'a fait, on a pu augmenter le taux de détection de tuberculose avec cette collaboration. Pour ce qui est de la lutte contre la mortalité maternelle, nous avons mis en place une collaboration entre les deux systèmes. Et cette collaboration, c'était de faire un réseau durable de surveillance et de référence rapide des cas critiques, les cas qui coûtent la vie à la femme. Et là, on a créé une communication entre le village et les centres de santé. Et c'est toujours les échanges qui se sont déroulés avec l'analyse des cas critiques, les comportements positifs et une référence vers la structure. Et cette expérience, nous l'avons menée et nous l'avons capitalisée dans un document qu'on appelle la guerre des femmes. La guerre des femmes capitalise 10 ans d'expérience de cette collaboration entre le milieu rural, les praticiens de santé, notamment l'accoucheuse traditionnelle qui est au village avec la majorité des femmes et une communication avec les centres de santé de référence et les centres de santé communautaires. Et là, nous avons dans ce document que nous capitalisons cette expérience-là. Et guerre des femmes, dans la langue bambara au Mali, quand une femme meurt en donnant la vie, on dit qu'elle est morte dans la guerre des femmes. C'est pour cela que nous avons mis ce titre-là comme nom des livres, le titre du livre. Voilà. Donc, pour venir à la COVID-19, aujourd'hui, dans la lutte contre les épidémies, que ce soit choléra, paludisme, VIH, COVID, il y a la nécessité de mobiliser non seulement les produits de la pharmacopée, mais les acteurs de la médecine traditionnelle qui sont au niveau communautaire, qui sont au niveau des villages, qui sont au niveau rural. C'est eux qui, informés, sensibilisés, vont informer les populations et les orienter. Et c'est cette expérience que nous faisons aussi bien dans la lutte contre la maladie à virus Ebola que l'Afrique de l'Ouest a géré, mais la lutte contre la COVID, nous sommes en train de travailler à une bonne implication des praticiens de la médecine traditionnelle. Et également, les traitements, on peut faire une exploitation judicieuse des plantes médicinales pour trouver des traitements. Donc, voilà un peu les éléments que je voulais présenter en termes de l'implication des praticiens surtout de la médecine traditionnelle dans la lutte contre les maladies et bien sûr les données de la pharmacopée. Les données de la pharmacopée aujourd'hui constituent des opportunités pour faire la recherche. Le centre que je dirige, nous travaillons surtout pour valider, faire l'évaluation préclinique et clinique pour mettre au point des médicaments à base de plantes. Et voilà la photo de notre centre. Et voilà donc ce département met au point des médicaments. Et aujourd'hui, on a un certain nombre de médicaments traditionnels améliorés qui répondent aux données, aux critères de sécurité, efficacité et de qualité. Et là, voilà la liste de ces médicaments qui figurent sur la liste des médicaments essentiels et dans le formulaire thérapeutique national. Donc, en conclusion, j'ai dit qu'il est important de renforcer et encourager la prise en compte de la médecine traditionnelle dans la formation des agents de santé, ce que nous avons commencé au Mali, renforcer le cadre de concertation entre les praticiens de la médecine traditionnelle et les praticiens de la médecine conventionnelle, répertorier les données de la médecine traditionnelle dans les indicateurs de santé, parce que généralement, on ne prend pas en compte cela, et dans nos pays, il est important de faire des décisions pour la prise en compte des praticiens de la médecine traditionnelle dans la pyramide sanitaire. Et tout l'objectif, c'est contribuer à améliorer la qualité des soins, c'est augmenter la couverture sanitaire en créant cette collaboration entre le milieu rural et le milieu urbain, et surtout entre les populations qui se trouvent en majorité en contact avec la médecine traditionnelle et pour qu'ils puissent bénéficier également dans la collaboration aux soins qui existent. Donc, je termine en disant qu'avec la prise en compte des aspects positifs des deux médecines, un autre système de santé efficace est possible. Je vous remercie.
Thank you very much, Professor Nokor. I really appreciate that. I think you provided some very useful reference to WHO work and frameworks on traditional medicine. And I think what I'm really excited about is the growing evidence base. I think everyone knows that with the biodiversity in Africa, there's some real treasures that we must be very careful of letting the rest of the developed world take away. It's the opportunity for us to be able to take traditional healing and build on it. And I think you're doing some wonderful work. So I think the question of how we work together in whatever circumstance, rural or urban, is the importance of reciprocity and understanding. So great stuff, and I'm glad that you're here. We have run into a bit of a time problem, and I don't want to take people too long after into our meeting. So we at maximum tend to go on for 3 hours, but tend to finish at 2:30, 3:30 or in 2.5 hours. So if we can, what we can do, and I think the group is fairly large, we can break into groups. It'll be just answering the question. I think taking questions now will stretch it out too much. There will be an opportunity later to pitch some questions. I'm going to suggest that we simply go through the questions which we have asked, which I think is also the same questions that Jana asked. How do we strengthen implementation or simply improve rural primary health care in Africa? And I think there's the time to reflect on it in the group. We'll come back at 15:15, so it won't be a very long group. And then we'll get some feedback from the group and then close with some synergized messages. And if there are questions at that time, we can deal with that. But I do think we need to give the opportunity for everyone to sort of meet in a more informal way. So let me break up into 4 breakout rooms. Sorry, that may be a little bit big, maybe not too big. Let's make it 5. And I will just open it up and just rearrange people according to how many facilitators there are. Yeah, let me just move 1 or 2 people across to another group. Okay, I think we've got one facilitator at least in each group, and we'll leave you to manage. I'll just move Rokia to the group with the with Professor Sanoho, and those who are French speaking, if you need to move to the room 4 where Professor Sanoho is, I think you might get some assistance with the French translation there. So I'm going to open up all the rooms, and you can please join that. We'll strictly work it on 30 minutes and see you in half an hour. And then we'll try and wrap up from feedback. So just before you go, please discuss the question, how to improve rural African primary care. Choose try and keep some records. And if the facilitators can please record the session. Thanks. Okay, if you're still here, I think just to help you get along, sorry, just click on the screen when it shows up showing you join room, just click on that. If you're still struggling, let me know, unmute yourself and just tell me. Let me just allow you to unmute yourself. So you can unmute yourself. If you're struggling in any way, just simply unmute yourself and tell me that you're struggling, okay? Zakir, are you okay? You just have to click on join the room and join that room. Amos, Blaise, Colin, Dionysia, Eleta, I think you're still in this room.
Hi,
if you're
Professor.
struggling at all, yes.
Could I join the group 5?
Is group 5, okay. Is it Dionysia, hey?
Yes.
Is that the one with Prof. Sanoho?
Yes.
Okay, she's in group 4. You are in which group at the moment?
3.
3, okay. I'll take you there. That's group 4. Yeah, okay.
Thank you very
fine.
much.
Okay. Okay, any other questions?
Now, I'm invited to join the group 4.
That's where Dr. Professor Sanoho is with the French translation.
But the one I would like to join is the group speaking French, because it's
that's the group. If you go to the group, you'll hear them speaking. At least Professor Sanoho is there, so and the interpreter is there as well. Join them.
Thanks very much.
Okay, all right, it's room 4. Okay, anybody else who needs some assistance? Is it James? Where? Okay, anybody who needs help? James, you have got yourself unmuted. Any help you need? Anybody else still here that needs help? I think I can help you move to the groups. You'll see you can join that. Any group, just click on the join and you can move across. It's a very short discussion. And I think use the opportunity to ask questions, but also to have some discussion about it. All right. Okay, pretty. Hi, everyone. If you're here and you're struggling, let me know. Blaze, Amos, Gideon, Helen, Keshwan, Takalani, Yogesh, please let me know if you're challenged. I can then give you some assistance. Okay, we'll be back at 1:15. Okay, there's a group discussion. If you want to join that, I think you might find it very valuable. Just click on the join group and go along. If you're struggling, just unmute yourself and you can speak to me. Apologies, everyone. I actually cut you short. It was supposed to continue. I'm not sure why it did that. Let me just simply put you back in the rooms. So apologies for that. You can continue. I'll just open the rooms back again. Sorry. If you just go back in, it's 15 minutes from now that you'll close up, but everyone should be back into their rooms. You just click and enter again. You should be all right. Sorry about that. Sorry about that, guys. Just you can join the room. Just click on join. I pressed something by mistake, so apologies. It's 15 minutes. We'll come back at 1:15, so please continue. If you're still here, you can just click on join and go back to your rooms. Apologies for that little break. So you were in room 2. Yeah, I think I put you in room 2, so that's fine. Now you are in group 2. You can actually shift if you are struggling. That's fine. I'll just move that thing to group 2. Okay, I've got 2 Vasus, but that's fine. Sorry about that. Colin, which group were you in? I'm sorry if you were kicked out. Anybody else who's in the wrong room, please feel free to let me know. Okay, anybody is in the wrong room, please let me know. I can just put you back in the right room. And apologies for cutting off like that. Keshwan, James, I think Yogesh, Amos, please, Helen, Jane. If anyone here is struggling, you are able to unmute yourself and just tell me if there's challenges. Otherwise, you can take a rest until 1:15. Everyone will be back in a few seconds, so it's great to see you guys still hanging out. Thank you. Great. Great to have everyone back. Thank you for taking our time like that. I know it was rather short, and I'm sure you'd have loved to chat some more. But we don't want to stretch your patience also with the overall timing of this meeting. So let's get some feedback, and I think we want to really get as much feedback as possible. I think if you have any questions, feel free to use this occasion to put them into your the chat, and we will try and use that to kind of get some feedback going along. And if you want to write some of your thoughts in the chat and some of the things that you think are missing from the sort of facilitators, please feel to do that. So perhaps we can start with Innocent. You can just run through that briefly with us. Innocent, do you want to start and unmute yourself? And then the other groups, I will just trust the facilitators to just add in this into the chat, as well as to sort of speak to us about it. If they can't do that, you can chat about it and then email it to us later at my email, which I'm putting into the chat. But please, if you can put it into the chat, be great. Thanks, Innocent, go ahead.
Yeah, thank you, Shabil. I have already actually pasted our points into the chat for everyone
just some
to
quick
see.
Comments around it.
Yeah, but the quick comments, I think, how we can improve rural PHC in Africa, one of the key things that the group came up with was to revisit the value we give to primary health care and also make it known to the policy makers. And then you also needed to really let the policy makers know that primary health care is not basic care, but essential care, and therefore needs investment. And you also need to make a business case for PHC. How much money will the government save by investing in the PHC, but more so in the rural areas? And we also thought that we should use the locally available support systems to support PHC infrastructure. For example, one can use a school where there is no building for the health facility. The school can donate one classroom, or it can allow the school building to be used over the weekend for provision of basic health services. And also we noticed that accessibility is a problem in the rural areas, and the group felt that use of mobile clinics, for example, just using a bicycle with a few essential medicines and medical supplies, can actually bring services to the communities by just using a simple method of movement. And then we also need to appreciate the role of indigenous knowledge in managing health care, because much of this is really quite relevant. And you should also have a monitoring and evaluation mechanism for rural primary health care to, first of all, know where we want to be and whether we are and how we shall get there, and also be able to know how we are moving along the journey and whether we are achieving what we set out to do. And also, really, quality assurance is important. So there is a need to have a quality assurance mechanism or a system for rural PHC. And finally, last but not least, we need a robust health management and information system for rural primary health care, which will actually be a gateway to generating information that can actually, again, make the case for rural PHC. Thank you very much. That is what came
wonderful. No, thank you very much. Wonderful stuff. And I want to say that these notes are very important. They're part of what we want to incorporate into documentation as we're going forward. So this is really sort of picking your brains and trying to get really clear ideas as much as we can get to try and use in our documentation. So Kelechi, maybe you can present for us, and or any other group. If you are presenting, hopefully you've got some notes, put it into the WhatsApp group, the group as well, or email it. So Kelechi, do you want to present?
Yes, thank you very much.
Go for it, Kelechi.
Oh yeah, for room 2, we had about 6 participants from different countries around, and we came up with the problems, then the solutions to this problem. So we were able to come out as a group to outline some problems that we noticed in rural PHCs in Africa. So top on the list here, we have lack of will by policy makers in Africa. We noticed that our policymakers do not have the will to do not make health a priority in Africa. So now to tackle this, though there was an Abuja declaration in 2001 that said each African country should have 15% of its total budget for health, and most African countries do not have up to 10% of their budgets for health. So poor funding is an issue in Africa. So this affects the rural funds to the rural centers. So now we came up with the solution that if our leaders or policymakers would make health a priority, provide adequate funds for health, this would, in the long run, translate to proper funding of our PHCs in Africa. And also we noticed that we have a lot of corrupt leaders in Africa. So this affects the success towards achieving universal health coverage in Africa and our rural health centers. And also among health workers, there's a form of corruption among health workers, because those health workers who are posted to rural community for rural postings find ways to bribe their way so that they are not posted. They don't get to go to those rural communities and discharge their duties. So we came up with a solution for this is that if there are adequate, proper legislation, laws that would make people accountable or punishable when they are corrupt or when they steal public funds, this would help deter people from stealing public funds for their personal use. And also we came up with an issue of lack of proper payment or remuneration for health workers. So people need to be motivated to discharge their duties. Health workers have bills to pay or they have families to take care of. So if they are not properly paid, if they don't have good salaries, they would not be motivated to discharge their duties. So the solution to this still boils down to the fact that our leaders, our politicians needs to fund the health system, raise the finance or the salaries of health workers so that they'll be motivated to discharge their duties. And also we notice that people are not patriotic enough as citizens. This on its own affects the discharge of duties in rural settings. So if people are more patriotic about their country, they would indirectly improve the health system. So also we came up with sensitization of people about health issues in schools. This will boil that if people are sensitized about their health problems, right from high school down to tertiary, to university level, they would know how to conduct themselves, know how to take care of themselves. And also if they are sensitized, they would know that they are not supposed to steal public funds for their personal use. They'll be more patriotic about their country. Then also, yes, we also noticed that in the rural communities, a lot of people are poor. A huge percentage, if not all of the people in our community are poor. So going there to sensitize people or work with people in the rural community because of the poverty, we would not go achieve much if we don't make it an all-inclusive package of their social and economic well-being of the people in the rural community. Then there's a gap. There's a lack of communication, or there's an isolation of treatment between rural health centers and the tertiary centers. So if there is a good connection between the rural centers and the tertiary centers, this will help further improve the health of individuals in our rural centers, our rural PHCs. Thank you very much.
Oh, good. Thank you for that. I think you've pointed out, very important problem, Kelechi, about, funding and prioritizing human resource in the middle of that, and also looking at accountability of, of healthcare practitioners and systems that work better, like, you've mentioned the link with referral hospitals. So great stuff. Thank you. Appreciate that. Mercy, you can go ahead, and then Mustafa after that. And I think maybe Bruce, you'll do last. I'm not sure. Yeah, let's go in that order. Okay.
Hello, everyone. This is the feedback from room 5. And I'll start with, I think, the answer that came up with most groups, the issue that governments must increase funding and resource allocation, not only for health, but specifically for rural health infrastructure and human resources, especially at the community level. Sure. And to go with that, there needs to be political goodwill towards improving primary healthcare, especially in rural settings. It's not there, probably because of lack of awareness or because it does not have any political pull, but it needs to be there for rural PHC to actually function well. The other thing is on active recruiting of human resource in rural areas for rural health. And we were given a good example from what South Africa is doing right now, where they train healthcare workforce specifically from rural areas. They recruit them from there from the first year of medical school. Then they provide bursaries for the rural students who have a commitment to then come back and work in the rural communities afterwards. And they've said that this has been working very well. I think that is something that we can think of and borrow. The other issue that came up is the issue of solving the right problem, where you need to, first of all, identify what the problem is, and it has to be the right problem, and apply the right solution. We were given an example from Nigeria, where in the beginning, rural PHC was under the local government. But then they realized when it comes to management, and especially management of funds, how it's organized, it was not doing well. So when and that was what was making PHC not work well, then they took the PHC mandate from local governments to the state governments, and right now it's functioning better than it was before. The other issue was on the rural social and economic development, because without housing, electricity, running water, transport network, social and recreational amenities, it's very hard for you to establish a good primary healthcare system there that works with the community and also works with the other hospitals and other healthcare networks. And 2, it's very difficult for you to recruit people to work in an area where there's nothing. So the rural socioeconomic development is also key. Then the issue of addressing accountability of leaders at the community level, and also accountability of those who work within the rural healthcare system. Then the other thing we can do is attract and retain experienced rural health workforce, and then engage in regular capacity building and also support supervision, because most of the time you find people are sent to rural areas and you're left on your own. Nobody comes to check on you, nobody comes to support you. So that's a very key thing. And also the proper motivation and remuneration of the healthcare workforce. There are lots of challenges in rural areas, and if someone is not motivating you and paying you enough to stay there, likelihood is that you will leave at the first chance that you get an opportunity. So that needs to be addressed. Another important point was the identification and integration of local stakeholders for appropriate community engagement and involvement. Most of the times we do not involve local communities when we're coming up with a healthcare strategy. So it's very important that they come up or they be involved in everything that you're doing at the primary healthcare level. Then also promoting community ownership of healthcare interventions at the primary healthcare level. It needs to come from the community so that when they own it, it's easier for them to actually follow through with it and actually support it. Then another important point was provision of information on primary healthcare to the rural population. That is engaging in intensive and extensive health education, also involving schools and any other rural networks that you have to ensure that there's proper health education. Another issue was the issue of cultural sensitivity, and I think another group has mentioned it, the issue of recognizing and integrating beneficial, traditional, and alternative medicine. You don't rival it, you integrate it so that the communities you're working with can also accept it. Because most of the time you find that 90% of your patients are using traditional medicine. You have no idea about it, but because you're against it, they'll never tell you, and they'll never put the medicine you're giving them. Then an integration of rural practice and community clinical practice in the training curriculum. We identified that a lot of curriculums don't have this. So how am I supposed to work with a community in the rural areas when that was not part of my training? I think somebody said, you play as you play like you practice. So if you're not trained to go and work in the rural area, there's no way you're going to work there. So it needs to be integrated into the curriculum. And last but not least, proper training, capacity building, and utilization of the community health volunteers, especially by having proper regulation and a scope of practice. Because we had a discussion around the issue of community health volunteers, and Paulo, a point was brought up that sometimes the idea is abandoned because they go out of their scope of practice, they start practicing medicine themselves. And we said the solution to that is continue working with them because we do not have enough human resource yet. But the point is we train them appropriately. We train the community to identify what they are for, what they can and cannot do. And also we make sure we supervise them to work within their scope of practice.
And as a team.
That was it from room 5. Thank you,
Wonderful.
everybody.
Gems, great stuff. Thank you, Mercy. And I really hope you can put it either in the chat group or email it to me. All these ideas, I think it's really been wonderful. I was struck by the fact, an important issue of infrastructure, not only for the attracting personnel there, but the social determinants of health and all that matters in rural communities. So great stuff. Let's go to Mustafa. I think he's put out some ideas. Mustafa, if you could just highlight some of the key things. I think you pick up on the conversation from Mercy. Go ahead, Mustafa.
Yeah, exactly. Much of what you said is really in line with what Mercy has just said.
Yeah.
What we really discussed in our group was that we have to look at reality. And there's a lot of idealism and things that could, take time to develop. But in the time being, currently, what do you do? And that's basically most of our discussion was around. Currently, we know the problems that are being faced. The lack of financing, the lack of infrastructure, the poor remuneration. But in the time being, before you get the political drive, before you're able to get the funding to increase, before you're able to improve the infrastructure to these places, what do you do? So that's what we discussed. And one of the key things that we looked at is, since we already have, we have Professor Rukia with us. So we carried on the discussion with traditional medical practitioners and how they could be integrated into the system. And looking at how Kenya has done that as well recently. So it's really an important resource that we could look at. It will help to detect cases earlier and manage them even better. Community health worker programs, as Mercy has mentioned already, it's something that is very resourceful. And we saw an example from Ethiopia. The participant from Ethiopia in our group also mentioned that it was very instrumental during the COVID era, as they were able to get to the household level, not just in policies. So also there's the idea of recruiting doctors, because if you look at the primary healthcare team in most settings, the doctors are lacking. So how do we recruit doctors in the time being before we're able to increase production and retention in the whole country? And we looked at some countries actually have programs where recent graduates don't get their full practice license until they practice in a rural setting for a year or two. And that is a way that we could get doctors there, at least for a year or two before the next batch are graduated, and those probably would leave. And a key thing that we discussed is that the community should not be left out in the discussion. A lot of the times the ministries of health and discuss at the federal level and just implement policies and bring them down to the community without actually listening to the communities. Okay, what's your reality and How can we use your reality to help solve the problem? So it's important to listen to them first and know what they're comfortable with. For example, with the traditional medical practitioners, that's something that you know as a reality the communities accept. So you go through that and find a way to integrate them and use them as a way to solve healthcare problems. So I think that's a summary of what we discussed in the group.
Great stuff. And I think I like the idea, if you know, of us knowing that we in fact have a considerable amount of influence and power in communities as working with communities, and our ability to get them to agitate and advocate for themselves, to shake the tree. So good stuff. And I think we have a role in that, in supporting communities to do that. Wonderful. So our last group presentation will be from Bruce. Bruce, will you present, or anyone else for the group 3? Go ahead.
Sure. We had a really good group, and I won't go through some of the things that obviously have been talked about, but I think Jane certainly brought up about, and others brought up about, the need to improve conditions more generally, and I take the point made a moment ago that that takes time, but I think we need to be wanting to do that and helping to do that. We talked about how to influence policymakers. Sandisaway from Stellenbosch was talking about that, and I actually noted from our WHO one meeting the other day that in the Philippines they are actually offering to educate policymakers, that some of the policymakers didn't know about what was happening in the communities, and it was a chance to talk to the mayor and give the views, because a lot of the time they were wanting ideas, but no one was talking to them. So Pierre from Burkina Faso was talking about they're looking at mobilizing families and giving them the resources to do sanitation, education, health within the family. So to try and motivate those families. And finally, Danny was talking in particular about microclinics, and just saying that a lot of centralized agencies have some money, but they don't know how to spend it in the communities, so it's either wasted or not spent wisely. And actually having a facility that goes around and negotiates with the visiting services to say, if you help us, we will help bring people to your clinic. We will coordinate your clinic. We will do that. So value adding onto actually providing the value of community, the value of the local knowledge. It's got a value to it. It's sellable really in a way to central agencies sometimes who don't know how to access the community, and that local knowledge can be valuable, and just recognizing that. So they were just some of the thoughts, plus obviously the things that have been mentioned by the other groups we fully support too.
Wonderful. Thank you very much. I think those were really great insights. And I think that all of this, we hope we can gather together and be able to, to put into work that we do. I think we want to be able to take it forward, advocate for it. I mean, we've shared it now, and there is going to be the video that's the recording of this, so it's available. I think if you can use it, remind yourself of ways in which we can do things. The presentations, if I can just request all the presenters to email them to me. I've got my email there. You can see it again. Please email all presentations to me, and we'll have the recording and some of these notes, perhaps a report on the on this thing. So please send that to me. I think we're going to make this available, and then we're going to try and incorporate it in. I don't know if there are any other comments and closing remarks. Perhaps we can just get some closing remarks from this whole interaction from different people, and perhaps I'll start with Rokia. Rokia is here, I hope. If she's left, I think she's left. Perhaps, oh, you're here. All right,
Oui.
great. Yes,
Merci.
yes, go ahead.
Je crois que cet exercice est important, mais c'est quelque chose que j'aimerais dire que pour améliorer les soins de santé primaires au niveau communautaire, il faut que le système de santé prenne en compte officiellement. Parce que le médecin, les agents de santé qui sont formés, qui sont sur le terrain, ils ont un organigramme de l'application des soins de santé primaire et généralement, il n'y a pas la médecine traditionnelle. Moi, je crois qu'aujourd'hui, il est arrivé temps, de nombreuses années après Alma-Ata, tout le monde est devant la réalité qu'il n'y aura pas de couverture sanitaire sans tenir compte de ces ressources de la médecine traditionnelle et leur prise en compte va nous aider à avoir les communautés. Nos expériences, c'est ce que ça montre, que les communautés ont confiance à ces praticiens. Ils ont recours à eux. Et donc, ces praticiens peuvent nous aider à les orienter pour qu'ils bénéficient des systèmes de santé mis en place par nos gouvernants. Donc, il faut mettre des moyens à la disposition de cette médecine traditionnelle. Plus de 80% des Africains utilisent cette médecine traditionnelle. Mais en termes d'équité, la majorité des fonds sont alloués au système conventionnel. Donc, nous faisons le plaidoyer auprès de nos autorités pour qu'on change notre approche sur le savoir traditionnel africain. Voilà, merci.
Wonderful, wonderful. Thank you. And I think just in response to that, I think there's always this, from allopathic medicine, this expectation that regulation must come down from government to be able to find ways to negotiate with traditional medicine. But I think this can happen even on the ground as clinicians, as healthcare workers, that we find ways to negotiate that sort of rapport with traditional medicine. And I think the community health workers can be a sort of way to do that. We certainly do it in my practice in the public service in Soweto. So great stuff. From maybe Yana, if Yana's still with us, and then Innocent. Yana, go ahead. Any thoughts, closing remarks?
No, just a really great active discussion in our group. And I see Nduvo's comment in the chat. Also, very interesting approach, being cognizant of the collaborations we make, the people who we bring into our team, how do we ensure respect and mutual practice. So I really like this. I think it's been a very good process for me to also engage in. So thank you very much for the opportunity.
Wonderful. And I mean, I think we didn't quite get that. We can still do it quickly, but the participation is across Africa. And I think that, let me relaunch it, but I'll share the results. But we've got people from Southern, Eastern, Western Africa, some from outside Africa, and, nurse, clinical associate, doctor. Pity we don't have a community health worker, but others as well. So I think it's really a diverse mix and a really useful platform. So great to have you here. And I hope you benefited from that engagement, especially in discussing things and hearing voices from these different places. So thanks, Yana, for that. Innocent, do you want to share some closing remarks as our president before, or shall we do Bruce first and then yourself? And okay, you can close it. All right. Bruce, perhaps you can speak and then Innocent can close with these, closing remarks as president. Go ahead, Bruce.
Yeah, look, thank you so much for involving me in the discussions. It's really heartening to hear the effect you're having within your communities and the great ideas that you've got. As a rural person, I think there's a lot of power in rural communities that we all need to harvest. We need to work with our communities. I thought the discussion around traditional treatments and things was very good in that way. But it is about partnerships. It's about working with communities. It's about helping them to get organised, to have some control. In our Aboriginal communities in Australia, they have a saying that nothing about me without me. And I think that's just such an important process. And that's what I hear you saying tonight. So thanks, Shabir, for getting this organised. Thanks, Innocent, for getting this organised. It's been an inspiration to be part of it. Thank you.
Wonderful, and really appreciate you coming along and being part of this as well, and all the colleagues from the Wonka Working Party. So really appreciate that. Over to you, Innocent. I think closing remarks, and then we can close the meeting.
Yeah, thank
Your
you
thoughts
very
overall.
much, Shabir. And on behalf of AfroPHC, as the president of the African Forum for Primary Health Care, really I extend sincere thanks to all of you for sparing time to attend this event. And just to let you know that we really have regular such workshops. Please, whenever you see the advert, come along. We must get our voices together. Really, our vision as AfroPHC is to improve and advocate for primary health care, particularly on the African continent, but working in collaboration with other partners across the globe and other organizations which have the same vision as AfroPHC. Really thank you very much, Shabir, for making sure that this workshop happens. And we are really very grateful to the Wonka Working Party on rural practice for partnering with AfroPHC and WHO to really make sure that the voices for primary health care are coming along. I really thank you very much all and wish you all the best. Please looking forward to our next discussion where we again get our heads together. Thank you very much, and I wish everyone a good morning, good afternoon, and a good evening.
Bye-bye, everyone. Take care. Please go check our website out.